So I'll have to say personally, I've heard things here today that about aHUS and teammates that I have not previously heard. This has been very enriching and hopefully will continue to be so. So we're going to have another patient perspective. Megan, if you have a free moment there, I know you're caring for others at the same time. But our next segment is going to be pregnancy and aHUS. And this is a topic that I was communicated by folks in the aHUS Alliance is a big deal, is an area related to aHUS that they don't have enough, patients don't have enough information about. They don't know what to do. Pregnancy happens all the time, so there's this reticence about becoming pregnant, not knowing what's going to happen during the pregnancy or afterward related with aHUS. Megan, could you tell us just a little bit about kind of your experience?
Introduce myself again for all of the people who weren't here earlier. I'm Megan. I was diagnosed on my 19th birthday. I had miscarried just a few days before then, and was told when I was diagnosed, you're never going to be able to have kids, so just put it away from your mind because it's not possible. And if any of you look around today, I've got my youngest here, so obviously it is possible. When I was diagnosed, I had been having a really bad pregnancy, problems from day one. I was told to be on bed rest, don't get up unless you absolutely have to go to the bathroom, and that's it. Okay, cool, I'm 6 weeks pregnant and starting out on bed rest. I went to doctor after doctor after doctor, and nothing got better. I was finally told that I had what they call venous pools, which are little pools of blood behind the placenta, causing it to tear away from the uterus, and told that I would not make it to 24 weeks, much less full term. So I actually had one doctor tell me, don't get attached. You're going to lose the baby. Just don't care for it. So at 15 weeks, I was feeling a little funny one morning. I got up to go to the bathroom, and I was going to come right back down to bed. As soon as I walked in the bedroom, I hemorrhaged. It was quite a lot of blood. I'd gone to the doctor immediately, and I thought, oh my gosh, I just miscarried. This was the point that they were telling me about. And my baby was still healthy. He was perfect. He had a heartbeat. He was doing great. So the doctor just brushed it off and said, oh, it's normal to bleed during pregnancy. Not that much. Pretty sure you don't lose that much. But he sent me home. Okay, go back on bed rest. That night, about 11 p.m., the same thing happened again. I had gone back to the same emergency room and was told, you're as white as the sheets. It is not normal to bleed this much. I don't know what he was telling you, but you've lost 7 to 8 pints of blood. You need a transfusion. So I was admitted and given a transfusion. They monitored my baby closely, and as soon as I was released from the hospital, I went to go see a high-risk OB. In the hospital stay, I had seen an oncologist who at the time I thought had a very terrible bed manner. He came in, was just really relaxed, asked me what was wrong. I explained my issue, and then my mom said, oh, we've got a history of TTP in the family. Her grandfather died of it. He said, oh, okay, and just walked out of the room. Okay, cool. So that was really awkward. So I was sent home from the hospital, go to see the high-risk OB. She tells me, you have a tear in your cervix. You're losing blood at a rapid rate. So you're not going to be able to keep the baby much longer. 2 days later, I miscarried and was sent home and told, just heal. Nothing should be coming up. You're fine. Just heal. The very next day, I returned to the hospital. I could barely stand. I was still extremely pale, still losing very much blood, and was told, okay, well, we kind of figured you'd be back because of your lab results. Why didn't you not say anything to me? So they already whisked me off to a room and ran test after test after test, only to come back and say, your kidneys and liver are failing. Fantastic. Well, you probably just have HELP syndrome, so we're not going to worry too much about it. Okay, great. So another test was run. Finally, the Adams test had come back. And I saw the doctor with the terrible bedside manner again. He said, go ahead and get her on Soliris, get plasmapheresis done, get her all of her vaccinations, but do it today. I don't care what it's going to cost, whatever I have to do, I'll pay out of pocket if I need to. So I started Soliris on my birthday in 2012. And from then on, I've been just slowly healing. Now I'm getting infusions every 6 weeks and doing fantastic with it. In 2013, I found out that I was pregnant again. My doctor gave me the option. He said, you can terminate it or you can continue. Nobody has continued with atypical aHUS after diagnosis. So there's no guarantee that you'll keep the baby or that it won't kill you. I have very strong views against abortion unless it is absolutely necessary. But I just couldn't bring myself to do that. So I decided to continue the pregnancy. It was a normal pregnancy. I saw a high-risk OB who knew a lot about aHUS, worked very closely with my doctor, and July 7th of 2014, my oldest son was born. Sorry, this hard. He was born via C-section because I thought that my body's already under enough pressure, might as well just take the easy way out, I guess. And he was healthy, perfect and healthy. He's 3 years old, just turned 3 years old last month, beginning of last month. Still perfect and healthy, playing baseball and all of the fun stuff that little boys do. And November 20th, 2015, my second son was born. Healthy, perfect. Still remained on Soliris every 2 weeks. Oh, sorry. And December 26th of last year, my daughter Adeline was born. Perfect, healthy, no problems. They were successful pregnancies. My doctor took care of the rest. My doctor made sure that I was okay because my doctor knew what to look for because he was informed. My OB knew what to look for. He was constantly monitoring my platelet counts, monitoring my kidneys and my liver all the time. All three were C-sections. So as far as can you have a natural birth, it's been done once that I know of, but I did not do it. I was not brave enough to try that.
Megan, thank you again for such a compelling story. It is pretty dramatic what I think we can say we've seen locally here as well when it comes to treatment of pregnancy in 2017, the patients with aHUS as compared to, say, even 2012. Dr. Craig Gordon is going to tell us more about his perspective in that regard. Dr. Gordon is a member of faculty at the Boston University School of Medicine. He's also director of the Renal Fellowship at BMC, and he's a specialist in pregnancy-associated kidney injury. really appreciate getting to know him over the last few weeks and months here, and I'm sure he has reviewed his slides. He has some excellent information to communicate to us, so thank you again.
And thank you, Andrew, and for the organizers. It's a true privilege to present to everyone here today. And it's a difficult act to follow with what Megan said. I mean, when we look at the challenging dilemma of pregnancy and TMA, we heard it about as beautifully as you can, as far as the diagnostic dilemma that people faced the first time and the challenging decision-making that was faced in the future. And I'm going to try to cover both of these areas over the next 30 minutes. Here are my disclosures. My outline today, I'm going to focus first on the pathogenesis of TMA specific to pregnancy. There's a few differences that are important for us to all be aware of when we're trying to think through the differential diagnosis. I'm going to then review the major TMA syndromes and maybe more accurately the major causes of pregnancy-induced acute kidney injury associated with pregnancy. So I'll spend a little bit of time on TTP, most of my time on aHUS, a little bit of discussion of HELP as well as pre-eclampsia, which may not even accurately be characterized as a TMA. And I'll try to give a few hints to people clinically about how to differentiate them from one another. And then at the end, I'll take the perspective of someone who's considering pregnancy, as Megan did several times, and in 3 different groups. One with known previous aHUS, either pregnancy or not pregnancy associated. A second group of people with known mutations that could be a risk factor. And the third would be with a family history. And I'll try to tackle all this over the next little bit. So I'm going to begin with a case, which is something I'm borrowing from the literature just because it's a really nice case that highlights a lot of the really key points and has some nice images that will help us understand things. So this is a 26-year-old woman and is typical for aHUS, is admitted 1 week after the birth of a first child. Her creatinine was 6, hemoglobin 3.6, platelets 49,000. LDH was very elevated. Haptoglobin actually wasn't reported. And schistocytes were seen in the smear. And it turns out they took really the only other relevant history was that her uncle on the paternal side had aHUS, which had recurred twice after transplant. And the uncle was known to have mutations in complement factor H and I. Ultimately, the patient was later found to have the same mutations. Her course is typical for what we see, which is plasma exchange was started, and as is usual for these situations, the heme parameters improved, but the renal function didn't. She started dialysis, and eculizumab 900 milligrams was administered quite quickly by hospital day 3, so this was a fairly quickly made diagnosis. Probably the triggering thing was retained products of conception, which were managed as the usual OB type management of these things. And then there was, as you'll see in the next slide, some confusion about what was going on. Eculizumab was stopped, plasma exchange was restarted, and then ultimately, and this is really the key to this case, was the recognition that the eculizumab dose wasn't high enough for the degree of activation of the alternative pathway of the complement, and basically a higher dose was used and readministered anytime the CH50 rose above 10%. And I'll show you in the next slide how well things work, but basically her heme parameters and renal function improved to a normal serum creatinine. I'll just show this graphically in a moment here. In blue here is LDH, which was very elevated on arrival. In red is platelet counts, which were very low. Okay, the scale is here on this side of the diagram. And here is the renal function. And at the top, you can see the early attempts with treatment with plasma exchange here with these vertical lines, the lower doses of eculizumab. And importantly here is this row, where you can see in green, incomplete blockade of terminal complement, and in red, complete blockade with the larger doses of eculizumab. And once you got to the larger doses, as you can see, LDH came down, platelets climbed into the normal range, and kidney function improved. So this is really a beautiful example of sort of the typical story for pregnancy aHUS, and also probably the best form of management we can see. So moving forward, let's talk a little bit about pregnancy AKI and the different sort of processes that can cause this. It turns out that in some parts of the world, pregnancy AKI is very common, and this is due to septic abortions in some places where abortion is not regulated and done, and actually the dramatic decline in pregnancy AKI in the developed world is actually partially due to these types of practices, but also better control of hypertension during pregnancy, better control of preeclampsia. And so now pregnancy AKI is sort of a late in pregnancy finding. Here's the D for the moment of delivery. And you can see a series of obstetrical emergencies as the cause, and then the ones we're going to focus on today, which is what's alluded to here as ADAMTS-TS13 deficiency TMA, also known as TTP. You notice it's a little bit to the left here of complement alternative pathway dysregulation TMA, or aHUS, which is something that occurs a little bit later in time and usually in the postpartum period, as our case highlighted. Going to also spend a little bit of time, not quite as much, on preeclampsia and the HELP syndrome. For those of you not familiar with HELP, it stands for hemolysis, elevated liver enzymes, and low platelet syndrome, something that can be easily confused for aHUS. So what about the complement system in pregnancy AKI? I think we've made a very strong case over the course of the talks that have preceded mine and those to come about the complement system really being critical in aHUS. And so that's represented here on this end of this diagram with lots of complement activation. On the other end of the diagram is preeclampsia, which is probably at best minimal role of the complement system and possibly none. And I'll present a little bit more data on this later. This HELP syndrome increasingly is thought to involve the alternative pathway of complement, and so I'll provide at the end a little bit of provocative information about this when we get there. So let's speak just a little bit about the pathogenesis of TMA specific to pregnancy. So the first to think about is TTP, okay? So it's a little bit controversial exactly what's happening, and Nathan maybe could help us clear this up a little bit from a hematology perspective. But basically, there's either a decline in ADAMTS-TS13 activity as pregnancy develops, or changes in von Willebrand factor parameters as pregnancy progresses. And basically, whichever is occurring, there's essentially a nadir of these two late in the second and third trimester. And this may be of evolutionary benefit because you want to, the risk evolutionarily is bleeding at the time of delivery, and this may be actually putting someone in a relatively hypercoagulable state to protect against that. Of course, there's higher rates of venous thromboembolic disease with pregnancy, and also there's increased susceptibility if someone develops inhibitory antibodies to ADAMTS-TS13. This is the nadir of the function of, let's say, for argument's sake, ADAMTS-TS13. And if you get inhibitory antibodies, this is going to be where the period of TTP occurs. Same would be true, by the way, for someone with a congenital ADAMTS-TS13 deficiency. And if you look at some of the studies that have looked at this, about 80% of cases of TTP occur in that late second or third trimester of pregnancy. And that will be in distinction a little bit to what we see with aHUS. And this is just some of the data. It's a little bit controversial exactly what's happening. This is an earlier study from 2001 that shows ADAMTS-TS13 activity in normal women during the first trimester of pregnancy, and you can see it's coming down to where the level is considerably lower by the third trimester. A second, more recent study, though, found no difference in ADAMTS-TS13 activity between baseline and the third trimester, but instead found a relationship where the von Willebrand factor antigen increased dramatically in comparison with, here in blue, a von Willebrand factor propeptide, leading to basically the ratio being down. And it's not exactly clear. I think the jury's out a little bit, and as a nephrologist, I'm probably have reached the limit of my understanding of this. But there is this sort of changes that set you up for TTP in this late stages of pregnancy. This is in distinction to aHUS, where sort of another interesting phenomenon is occurring, where, as we all know, most of these cases are associated with complement dysregulation in the alternative pathway. And you'd actually expect that aHUS would occur during pregnancy, and as I alluded to before, most of the cases are actually postpartum. And the reason you think it might occur during pregnancy is there's potentially a huge complement activation at the maternal-fetal interface, right? You have a foreign antigen, right? I mean, to speak sort of scientifically about it, that the mom theoretically should be attacking. And actually, it turns out in studies that were performed about 20 years ago that at the placenta there's dramatically increased levels of decay accelerating factor and CD59 in the placenta, which actually protects the normal maternal fetal interface from complement attack. And it simultaneously, if you have problems in complement regulatory proteins, such as seen in aHUS, you're actually protected while the placenta is there. However, those protective effects disappear with placental delivery, and this is perhaps in part why a lot of these aHUS cases occur in the early postpartum period. Interestingly, as with a lot of things with aHUS, most cases seem to be triggered by something, infection, bleeding, some sort of other thing that activates the alternative pathway of complement, and this process becomes out of control. Just show this graphically. Here's a very complicated image of the complement cascade. You can see the alternative pathway with the key steps being the C3 convertase, and down here the C5 convertase. I'm going to highlight, the role of decay accelerating factor here, and here, and CD59. So as long as that placenta is there, the brakes are there for the system. But on delivery of placenta, if something else triggers things, such as an infection, that's where the problems set in. So shifting a little bit from pathogenesis to clinically, it's actually very difficult, as we've heard in a lot of the discussions from the people affected by these diseases, including Megan today, to diagnose this. And it's really tough in pregnancy, it turns out. And so there's a couple clues you could use clinically. The first is timing, postpartum versus second or third trimester, as I alluded to. Other times in pregnancy, it's less likely, but not zero, to be TMA. So you want to have a suspicion. I'll show you some data to support that statement a little bit. You want to look at the lab evaluation and try to use that to distinguish between these four major causes I alluded to before: the TTP, aHUS, the HELP syndrome, and preeclampsia. And that's going to be the usual TMA type labs like platelets and MAHA, serum creatinine, LDH haptoglobin, Adams TS13 activity and antibody testing, and something that we don't normally talk about much in aHUS in general, but is the liver function test, but it's critical here with this HELP syndrome in our differential diagnosis. So here's an issue of the timing. You can see the distinction here between TTP and aHUS, which I think if you keep this image in your mind when you're facing cases is going to help you much of the time. Not all the time, but much of the time. Here's the lab approach. We're going to look, as alluded to earlier by Dr. Francis, for thrombocytopenia, MAHA, renal involvement. Once we hit this point, we're looking at Adams TS13 activity. If that's low, it's going to fit better for TTP. If it's not low, with the caveat that you have a normal decline during pregnancy, so things get a little bit trickier of what's low and what's not low. But if it's not low, it fits better for aHUS. And in this case, pregnancy aHUS used to be considered a secondary TMA, but as I'll show you, most of the cases are aHUS associated, as I think most of us in this audience know. So let's spend a little bit of time on TTP, and then I'll switch to aHUS. So again, 80%, this works out very nicely, this literature, because everything sort of, if you can remember 80%, it works for many things in this area, but about 80% of cases are diagnosed late in pregnancy, with the remainder being postpartum. They usually have severe and extreme thrombocytopenia. A major decline in GFR is less frequently seen. And again, we're going to use Adams TS13 activity and antibody testing to identify this. If the level of Adams TS13 activity is extremely low, less than 5%, you've made a diagnosis. If it's in this 5 to 10%, you're going to need a little bit of help from a hematologist with this, I think, and some judgment. And this is where a little bit of the art of medicine comes because of this normal decline during pregnancy. How do we manage TTP in pregnancy? Well, we manage it similar to TTP in other circumstances, with the exception of thinking about the well-being of the fetus, okay? So plasma exchange, most of us in the audience know, is very effective at clearing the autoantibodies, if present, and also administering normal Adams TS13. When you look at this in pregnancy, you'd wonder if there's any increased risk of plasma exchange in pregnancy. Turns out there's really no increased risk. It's the baseline risk of anyone who would be treated with this, which is the risks of catheter infections and complications of the catheter and complications of the treatment, but there's nothing unique to pregnancy. Corticosteroids are often used for TTP. there's really, the only caution in pregnancy is there's really no efficacy data out there for their efficacy in TTP during pregnancy. They probably work, but this is something that needs to be done in sort of consultation with the obstetric and gynecology specialist. And finally, rituximab, which is sort of gaining increasing traction for TTP, is FDA category C in pregnancy. So that's one where you have to sort of use judgment and risk-benefit analysis. There's a lot of experience for rituximab and TTP, but actually very little in pregnancy-associated TTP, at least in the literature. And one of the concerns here is it's an antibody, as an IgG1 antibody, it can be, it undergoes transplacental transportation in the third trimester. So there's a concern about it actually entering the newborn circulation. And actually studies that have looked at this have found that it's cleared typically within about 3 to 4 months. And so that sounds a little worrisome that this agent is potentially having a biological effect. There's a fair amount of data on rituximab in pregnancy for other conditions. And basically, the take-home message, I think, is fewer than 10% of newborns have evidence of B-cell depletion, neutropenia, thrombocytopenia. But again, with all this stuff, it's a risk-benefit. And I think these long-term data are out there. I think, I don't know if anyone here is someone from an OB perspective, but when you're looking at this, the well-being of the mother often predicts the well-being of the baby, right? So we want to make sure we're taking care of the mother, and as long as our treatment is not known to be harmful to the baby, we don't want a mother with a platelet count of 7,000 with potential complications both to the mom and to the baby. So I think this is how to think about it. Shifting gears to aHUS. So calling this aHUS in pregnancy is a little bit of a misnomer, right? Because 80% of the cases are diagnosed postpartum, so it's associated with the end of pregnancy. With the triggers I mentioned before, complement activation generally occurs. The tricky thing is distinguishing aHUS from the other 3 things in the differential during pregnancy, that last 20%, okay? And I'm not going to come here and give you like an answer of this will work perfectly. There's no blood test or any sort of thing you could do that this is voila, here's your answer. But there are some clues, okay? So we alluded to before that compared with TTP, aHUS generally has much more severe renal involvement and less severe thrombocytopenia. Compared to the HELP syndrome, the LFT elevations are typical for HELP, it's part of the name, but less common. I wouldn't say zero in aHUS, but less common in aHUS. There's some differences you could figure out to distinguish aHUS and HELP later, but that doesn't help you when you're trying to manage the patient. They have a different prognostic, there's a different prognosis from a renal standpoint, but you don't want that 2-3 weeks later. You want to know what to do now, okay? So that's a very tricky one to distinguish, although I'll present a little bit of data on HELP that might make our lives a little bit easier at the very end. Finally, compared with preeclampsia, the typical MAHA and thrombocytopenia we see in aHUS are less commonly seen in preeclampsia. The really severe renal failure, it can be seen, it's just less typical, okay? So I think if you see that sort of pattern, you want to really start thinking very seriously about aHUS and have preeclampsia on your list, but a little bit more on the back burner. For those of you who haven't seen this paper, this is really a really important paper in the area that just came out actually this month in C. Jason by Bruel and colleagues. This is basically, if you look at the list of authors, this is who's who in aHUS in Europe. And basically what they did is they did a multi-center retrospective study of the registries of 3 major registries in France, Italy, and the UK. And they built on a prior study by Fakori et al. Of 21 cases from France, and actually now have 87 cases described of women with pregnancy-associated aHUS. I want to alert you very carefully to this time period, which is 1983 to 2013. So this is in the edge before, the tail end of this is when eculizumab started being used. So there's not going to be a lot of information on eculizumab in pregnancy from this, but there's a lot of information about the pre-eculizumab era. Importantly, these 87 women were 16% of all of their aHUS in women of childbearing age. So if you took the entire database of these 3 databases, This 87 was 16% of all women of that age, okay? So it's about what we think of as the prevalence of pregnancy-associated aHUS. And the study actually provides a lot of information that's illustrative to us. So here's the table 1 from the study, which presents one important factor here. 58% were diagnosed during their first pregnancy. That tells you 2 important facts. 1, that it's most common with first pregnancy, but 2, it's not uncommon with later pregnancies. And if you made it through several pregnancies, 2, 3, 4, or more, without aHUS, this is not a guarantee this is going to happen to someone. So that's going to be helpful when we're advising our patients later on. Second key point in this table is, although not perfect, if you could find information about either personal, obviously, or family history of aHUS, it can help you when you're trying to figure out the diagnosis. That was present, a family history, in about 16% of this cohort. Finally, what do they look like clinically? Well, the mean serum creatinine was 6 on arrival. 71% needed dialysis. The platelet count mean was 97,000, so very different than what we see with TTP. Hemoglobin was about 7.8, and you can see LDH was very elevated as well. And then finally, sticking with my rule of 80%, in this series, about 76, or pretty close to 80%, were postpartum. So again, aHUS postpartum, TTP, end of pregnancy. What about genetic testing? So they performed genetic testing on everyone in these databases, and basically they were able to find variants in the alternative pathway of complement in about 56%. Okay, so the remaining 44% tested negative in 2000, the 2000 or 21st century testing. Maybe this would change in the future with new discoveries. About 30% had complement factor H variant, 9% complement factor I, and 9% combined variant. So a lot of them did have abnormalities in the complement system. How about timing? So as you can see, almost everyone is in the postpartum period. Okay, these all clustered. The only difference between the triangles and the black versus white is basically first versus second or later pregnancy, identified complement mutation versus not. But basically, virtually everyone is in this window here. But don't be fooled. Some people could be much later, and some people can be considerably earlier, as early as like 16 weeks, 20 weeks, even less than 12 weeks. So you don't want to be completely reassured if a case that looks like aHUS is staring you in your face. Don't say, well, it's only 12 weeks where you don't have to think about this. It's classically in this early postpartum period, but don't be fooled. What do the outcomes look like? Again, in the pre-eclampsia era, we've heard a lot of the personal stories, right? This is numerical and sort of not, there's no feeling associated with these numbers, but imagine the feelings associated with these numbers. 53% of people who were pregnant had a different plan in mind, end up on dialysis. Another 19% with significant chronic kidney disease. People ended up with relapses. People ended up with post-transplant relapses. So this is a very devastating, as everyone here knows, situation. So how do we manage it in 2017? Well, I'm going to divide this into postpartum and not postpartum during pregnancy, because there's sort of two different, it's the same treatment, but it's sort of two different thought processes on the same treatment. So eculizumab, I think most of us in this room would recognize right now as the standard of care for these things, including in this postpartum setting. In the Bruel study, this recently published CJASN paper, 4 people were treated with eculizumab. It must have been in the tail end of this 2013 area. They were all treated postpartum, as you could see, and between 4 and 5 days 4 or 5 days after diagnosis in 2 cases. One was a month after diagnosis, and one was 2 months after diagnosis. Of note, and it's not clear which one is which, one of these people was diagnosed while pregnant and treated postpartum. And I don't know which one that is, at least from carefully reading the study. However, of these 4 who were treated, 75 had a complete renal recovery, off dialysis, normal renal function. The only one who didn't was the one with the 2-month delay before treatment. And again, I don't know if this is the one who was diagnosed during pregnancy or not, But I think we've all gathered, and from all of the experience that's been seen, and from Dr. Francis's presentation, time is the essence here. We really have to make diagnoses here. The case I presented in the very beginning highlights the importance of not just sort of cookbook medicine, eculizumab, follow this regimen on bullet point 1 and go and you've done your job. You have to really monitor them very carefully. They may require more frequent dosing, they may require higher dosing, and you want to use measures of terminal complement activity such as CH50, which is probably most available in clinical practice, to guide your decision. How long do you treat? I think that duration is not known. There's no answer to this. Certainly the period of risk is the sort of immediate postpartum period. How long does someone need to be treated? Could it be indefinite? Could it be for a shorter amount of time? I think that the jury's out on that question. And I want to highlight the importance of obviously meningococcal vaccination and antibiotic prophylaxis, which I think is even more important perhaps in treatment while pregnant, because you're managing two individuals right at that time, one who has a very immature immune system. And importantly for people thinking about nursing, at least in one study of people with paroxysmal nocturnal hemoglobinuria who were treated during pregnancy and then afterwards with eculizumab, and PNH is one of the FDA indications for eculizumab, there was no eculizumab detectable in expressed breast milk in the 10 people who were tested for it. I will, to sort of give the other side of the equation, there's one study that showed in a case report of one woman who the first expressed sample of breast milk, they could measure eculizumab, but subsequently no. So this is something that I think the jury is out a little bit on, but certainly the evidence seems to point towards being comfortable with the idea of the mom nursing while being treated. What about the during pregnancy situation? Well, there's not really very good safety data for eculizumab in pregnancy, except for we now have 3 cases which need to be published. But there is evidence from this other condition, PNH, okay? And there's this really nice study from 2015 by Kelly et al. That looked at 75 pregnancies and 61 women with PNH. And the issue with PNH, for those of you not familiar, is there's a risk of vascular thromboses, especially towards the end of pregnancy, for the reasons we talked about with the coagulation cascade. And pre-eclampsia, women who were pregnant, people were told when you're a woman, do not get pregnant with PNH because you had about an 8 or 15% risk of the mom dying from a thrombotic event. And so this was a very dangerous situation. Now with eculizumab, they can sort of work their way through the pregnancy. In this series, maternal mortality was 0. Fetal mortality, miscarriage rates essentially were absolutely comparable to both pregnant women untreated with PNH and also women, normal, healthy women in the world who were not treated. So there really wasn't a difference. One thing to watch for, though, is eculizumab was detected in 35% of the cord blood samples. Unfortunately, this paper, these authors didn't assess complement activity, but we have a case series of 2 out there from Halstenson, where they had 2 moms treated with eculizumab who themselves exhibited terminal complement inhibition, and the newborns did not. They had normal complement function. So it may be that even if this is slightly in the cord blood, it's not achieving a biological effect. And again, I want to really highlight the meningococcal concern before I move forward. What happened with these women treated with PNH? How were the kids? They were perfect. Good birth weights, good gestational age, no major issues during the hospitalization. And when they looked at developmental milestones, 100% met those milestones. So the babies really thrived. And we can see that here, better than anyone like 20 feet from me. So early data looks pretty reassuring for eculizumab in pregnancy. So let me spend just a moment or 2 on preeclampsia and the HELP syndrome, and then I'll shift to these sort of discussions about what you do with the process of thinking about pregnancy. Well, preeclampsia is quite common. 2 or 7% of pregnant women will develop it. It's associated with hypertension and proteinuria late in pregnancy. The creatinine is often elevated, but they often don't have dramatic thrombocytopenia or MAHA. And pathophysiologically, it's related to increases in angiogenesis related to these 2 factors, sFlt1 and endoglin. How do you manage preeclampsia? Well, the OBs take care of it often without the involvement of others. They deliver the baby. And actually, the renal lesion, if you were able to follow a pre-eclampsia, pre-delivery preeclampsia renal lesion, the classic finding is something called glomerular endotheliosis. That recovers postpartum. And with the exception of the worst cases, the moms are actually in quite good shape. The more severe cases, they can end up at risk of CKD. So is the complement system involved? I think this is probably not looking very promising that this is an issue. There is one study that looked at measurements of mutations in complement regulatory proteins and found a modest percentage in preeclampsia. Not clear if those are sort of the baseline of the population or somehow connected. At least in one study in mice, complement inhibition prevented them developing the preeclampsia lesion. But I think this is probably, when you have delivery as an option, it's not probably going to gain much traction, although I'll show you in a second where it might, which is in HELP syndrome, okay? So HELP syndrome, the question is it a TMA? So HELP, again, here's the acronym. It's actually a relatively common cause of AKI, and the distinction between it and aHUS is both can result in a need for dialysis, but often with HELP syndrome, as they recover from being sick, their kidneys recover without any specific treatment, which is different, obviously, than aHUS. Okay, but that's not how you want to make diagnoses, right? You want to make them like 3 weeks earlier. So how do you distinguish? Well, it's really tough. They both have AKI, they both have MAHA, they both have low platelets. So these LFTs are probably our strongest helper, and timing. HELP is usually something that occurs during pregnancy. aHUS usually postpartum. If you have someone who's pregnant and you're trying to distinguish the two of them, that is the area that's the most difficult. And you just need help from really the type of multidisciplinary team that Dr. Francis discussed to try to come to a consensus. If you look at the renal biopsy in HELP, it shows a completely different lesion than aHUS. There's only about 15% of the time do you see microthrombi, but you more typically see the glomerular endotheliosis type lesion that's just it's pretty typical for preeclampsia. If you do a liver biopsy, you actually see hepatic thrombotic microangiopathy. You can actually see microthrombi in the liver, so it's really a hepatic TMA. And at least in one series, when they screened for complement mutations, these were seen at about 40%, so pretty typical for what we see in the aHUS, this 40, 50, 60% range. How do you treat them? Well, delivery, if it's feasible, and the baby is at an age that's going to be safe. If not, steroids, maybe, plasma exchange, maybe. There's one case I could find on eculizumab, which was used in a woman who's 26 weeks pregnant, and basically they used it, got the disease under control for the next 2-3 weeks, long enough for the baby to be a little bit healthier and delivered a normal baby. So it's maybe going to get some traction, complement inhibition in the future, but I think we're too early to say. So let's shift just for a moment or two about the counseling side of things. So as you can remember, there's 3 different scenarios. Prior aHUS, whether pregnancy associated or not, the known mutation in that individual or family history of aHUS. So what do you do when they've had previous aHUS? Well, the recurrence risk is not known, but I would say pretty strongly it's not 100%, okay? So when you're advising someone, I think the advice of this is going to recur is not accurate, okay? And that's even without taking into account treatment with eculizumab. Okay, if you look at the Bruel study, 42% of the people were on the 2nd, 3rd, 4th, or even more pregnancy, which means a number of pregnancies occurred uneventfully in someone with a complement system mutation. It's not a guarantee that this is going to happen, okay? Unfortunately, we don't have much information except for what we learned from Megan about what happens in eculizumab-treated people in subsequent pregnancies. But I think your experiences are the experiences one would expect, that treatment keeps the disease at bay, even if a complement triggering event would have occurred. Eculizumab will keep the disease under control. But I think if you're facing these people, you want to do genetic testing, because I think that does give you some prognostic information and might help you make the decision about treatment or not treatment. Because it turns out, this is data from Fakori again, about 20 or 30% of people with complement factor H or C3 mutations will develop aHUS in pregnancy. These are people like not with previous aHUS, but if you knew they had a mutation, this is their risk, which is obviously probably about double that of complement factor I and MCP mutations. I think it's not clear, though, if the risks are different if you have these mutations, which is just, these are people de novo with the mutations, but no prior aHUS. So we don't really know if the risks are higher if you have the mutation and also previously had aHUS. I think the answer is probably it is somewhat higher, but I don't think anyone knows how much higher. And then finally, how do you manage someone if they are pregnant? Okay, this is weighing again the risk benefit of the treatment. Okay, if they're currently being treated and requiring eculizumab, I agree 100%. Don't stop it. If it's required to keep their disease at bay, this is not the time to play around and experiment. Okay, if they're not taking eculizumab, I don't think there's a strong case to throw them on it for the pregnancy, but you have to monitor them very frequently, as your OB did, and be ready to move with an action plan to initiate treatment as soon as it's a clue that this disease is acting up. So what about the second group, which is someone with a known mutation and no previous aHUS? So these people have this risk I alluded to before, depending on their type of mutation. And I think if they're pregnant, again, you're weighing the risk and benefit of treatment, okay? They absolutely need to be monitored by someone who knows what they're doing. So this needs to be an OB who has experience in the area, or the type of team we have at BMC, where you have a bunch of people who could look at the data, make a decision, and go from there. You need to monitor frequently for TMA. You can see I'm being very vague. There's no answer for what is frequently. Is it monthly, every other month? Every other month doesn't sound frequently enough, so we're talking monthly or even more frequently, okay? And be ready to start treatment. And I think prophylactic eculizumab in this person is not recommended. Their risk is somewhere in this range, and you're potentially exposing them to something they don't need during this entire period of pregnancy. And personally, I wouldn't recommend it in that situation if they were just someone at risk. What about this family history of aHUS? Well, you know, a lot of people don't think we should do gene analysis for looking for mutations in asymptomatic relatives. You just cause a lot of alarm and worry, and nothing may ever happen to those people. I think people who are considering pregnancy may be a different scenario, right? Because there's a predictable risk period. You know when they're at risk. You know that there's a certain percentage risk of this happening. You know, it's a little bit different than someone who just goes out in the world and might or might not get an infection. This is probably a different situation. But again, still not required, because if you look at those numbers, you're looking at maximum a 20 or 30% risk. And one could argue, why go through the concern, the worry, the nervousness of wondering what's going to happen that you know you have a complement factor H mutation, and maybe just go through the pregnancy and be monitored. So I think that's a judgment call, and each individual, both physician and patient, will have a different perspective on it. I think if there is a complement mutation, you need to monitor for TMA frequently. Even if there's no mutation, or if they weren't tested, you need to monitor frequently. And certainly whatever this is, it's going to be more frequently than the general practice for OB. You need to really keep an eye on people. And you need to have a team with experience, or at least an OB with experience. So finally, in conclusion, and thank you for your attention, the first question we face is distinguishing aHUS from TTP and the others. And I think the clues here are timing and lab parameters and getting some help if you're struggling with this. What do you do? The treatment after pregnancy is relatively straightforward. The treatment during pregnancy is the tricky one. For TTP, it's going to be plasma exchange and a risk-benefit analysis about rituximab or steroids. For aHUS, it's going to be eculizumab, and again, the well-being of the baby is tied to the well-being of the mother. So if we need to treat the mother, we need to treat the baby as a result, and it doesn't appear anyway that there's much of a risk. And then finally, when we're looking at counseling, genetic testing, I think, can be helpful. It's not required, but it can help you. Definitely close monitoring is the key, and being ready to go with treatment as necessary. So thank you all for your attention. Field any questions. Thank you.
There's a case presentation going around. I had heard a few of these evening talks about a patient that was, they were considering a diagnosis of HELP versus aHUS, and she started manifesting with symptoms at 13 weeks. The argument there was that it was too early for HELP.
Yeah.
But I think the overall set of data that's out there and that it's available is that this is really something that's happening almost at time of delivery. The question of whether or not something's happening in the first trimester, I don't think it's being reported. I mean, I think it's more so that the patient is being described as being infertile. And so, the typical evaluation needs to be completed there as compared to looking for aHUS. Anything that you saw when it comes to evaluation for multiple attempts at pregnancy without success as to when aHUS should be or TMA should be evaluated?
I think there's obviously a broad differential of people who have difficulty, both from a heme and a rheumatologic, with things like APLA syndrome, et cetera, and lupus. But I think it is probably something that should be on our list. I don't think it's on the standard list for this. It's interesting if you look at this study. I mean, one of the comments I made was if you look at the pathogenesis of aHUS, it's thought to be postpartum, right, because of this placental decay accelerating factor. But if you looked carefully at this figure from the recent Burrell study, there's there's 20% who develop aHUS relatively early. As early as 12 weeks, and some of them 24, 30 weeks, et cetera, of pregnancy. It's interesting, what those people seem to represent is people who have previous CKD or previous aHUS. Tend to be the ones who develop, not in the postpartum period, but during pregnancy period, which I think argues perhaps for this use of eculizumab in some of these people, because I think perhaps their kidneys are sort of set up already from prior damage for this. So I guess I'm sort of answering two questions in the same thing, but I think this question of difficulty. I would imagine if you're seeing a patient who's having difficulty becoming pregnant with a family history of aHUS, that's got to be high on your list.
Absolutely. I've got a list of questions here. I'm not going to ask them all, but just one more tricky one. We've dealt with patients previously, females that wanted to be egg donors. They wanted to donate their oocytes, and they knew they had a mutation for aHUS, but they weren't manifesting. And any comments there as to whether or not you think there should be further evaluation, or should OBs and GYNs be communicated that past information as to whether or not there's a mutation that's present?
This is from the perspective of the
of the female that is donating her oocytes potentially for IVF.
Right, who may be that.
It's happened. I'll just tell you, it's happened, and there's been bad results. Meaning to say, it turned out that both of those oocytes that were used, IVF continued and ended up having mortality of both of the neonates as a result of this diagnosis.
No, I agree. I mean, it sounds like that situation is something we need to be paying close attention to, and do need to. Yeah, it is. I think, in part to answer that, I would say this is a little bit where our team and the sort of getting OB involved in our team, I think, has become very key, because this type of question is a multidisciplinary, it's both ethical, but it's also different disciplines are going to have a different perspective on this, and sort of setting up protocols for this type of thing.
You can argue that not all mutations lead to disease, and they can have a normal lifespan, but a lot of them can manifest the disease and live all their life with, heavy and big burden disease.
Yeah, Dr. Francis brings up a good point here, and that is that there are people that live their daily lives into an old age with a known mutation. We've had these discussions kind of in different iterations, and one thought is that those people that are here and that are talking about their disease and they're 55 years old are those that kind of made it. And potentially those siblings that had a very intense form of the disease didn't make it past early childhood or even via delivery. So yeah, I think there's certainly at least a bimodal distribution here when it comes to presentation of disease and how to deal with these mutation analyses.
And I think also that distribution of disease is now changing with very effective therapy. So the face of it will change, and some of these decisions will change.
Dr. Gordon, thanks again for your time.
Thank you.